The upcoming informative session in Hall A, where our anterior segment experts will be discussing recently used intraocular lenses for management of aphakic patients, glued posterior chamber intraocular lenses, sulcus sutured posterior chamber intraocular lenses, or iris claw anterior chamber intraocular lenses. Also, our panelists will be discussing how to manage narrow pupil during cataract surgery, sphincterotomy, iris hooks, or iris stretching rings, how to manage drop nucleus during cataract surgery, close and refer, or insert intraocular lens and refer. In addition, our panelists will present updated surgical options for managing presbyopia, trifocal, and accommodating intraocular lenses. These interesting and informative topics will be discussed by our panel of experts. Professor Francesco Carones, Medical Director of Carones Ophthalmology Center, Milan, Italy. Dr. Athiya Agarwal, Director of Anterior Segment Unit, Agarwal's Eye Hospital, India. Dr. Amar Agarwal, Managing Director, Agarwal's Eye Hospital, India. Dr. Tjia Khiun, Cataract and Glaucoma Unit, Isala Clinics, Zwolle, Netherlands. Dr. Rafael Bilbao, anterior.
So, welcome you all for this session. It's a very interesting session for the anterior segment surgeons, for the cataract surgeons, and even for the posterior segment surgeons. We have a very exquisite presenters here, and we are discussing something. But first, I want to have everybody had the voting pad. Okay, so there is a question. If you can just play the question. So if it's a 55-year-old woman operated in a cataract surgery, she has done dialysis that occurred in nucleus fragmentation, and it converted into intracapsular cataract extraction. So it doesn't have capsule at all. So what would you implant? Would you implant the anterior chamber IOL? Would you implant the iris claw IOL? Would you implant the sulcus fixated IOL? Or would you do another thing? So can you vote now? And we'll just give you 5 seconds. It's not changing? Okay, done. So we are nearly split between the anterior chamber IOL and the, okay, anterior chamber is, yeah. Wow, okay. So the most, Dr. Agarwal will win. She is, it's sulcus fixated IOL and the AC IOL. Iris claw IOL has some chair and others has some chair. Okay, now, oh wow, okay. Maybe somebody in the anterior chamber will sit here, will stand here, maybe it will change. Okay. Okay, so we'll have the presentations, and then we'll re-vote again after this and see if you are still holding your opinion or no. We'll start with Dr. Agarwal. She will talk about the glued IOL.
Good morning, friends, and at the outset, I'd like to thank Allah and the entire Maghribi group for having my husband and me for more than 3 times, I think. So every time I come to this place, the meeting, MIC, we get so much respect and honor from all of you. Thank you very much for that. So this morning, I think everybody is tired because today is a weekday for you, we all know. So what I decided was, it is actually an answer to this question which you all saw just now. We started doing glued IOL in 2007, December, and believe me, there is no looking back for us. Be it aphakia or be it any posterior capsular rent or anything, we do not think twice before doing what I'm going to show you now. So can I request you to play my first video first? Thank you. The first video, please. Whatever I'm going to talk to you, I have no financial interest in any of the equipment and the instrument I'm going to talk to you about. Glued intraocular lenses, as you all know, are... The first video is... it's okay? Okay. A few tricks which I'm going to show you here is this. This is actually Marfan syndrome, a medical student, and in preparation for doing a glued IOL in this case, we have created flaps 180 degrees apart. So, if your horizontal diameter is more than 11 meter, you can think of doing a vertical glued IOL. In this case, you're seeing that's what we are doing. A 20-gauge sclerotomy under the scleral flap, which have been created 180 degrees apart, be it vertical or horizontal. So it has to be 180 degrees apart, which is very, very essential for any glued IOL to be centered and be successful. Under the scleral flaps, you have to create a sclerotomy, but be careful seeing that your needle should go slightly vertical, not horizontal, otherwise you will hit the iris and you will see the bleeding, and in that case you have to take your sclerotomy either slightly anteriorly or slightly posteriorly so that you don't hit the ciliary body at the root of the iris, otherwise bleeding has to be cleared first. Here, since this is a very a lens which is very not at all mature, so you can just use the cutter, and when you're coming to the iris, close to the iris, be careful, instead of cutter you move on to the aspiration mode and remove off the lens matter which is there. Once this is done, the intraocular lens forceps is loaded into the cartridge, and see that only you hold the tip. You can see inverted 7 sign, and you see here I'm holding only the tip of the IOL haptic, and you can ask your assistant to reload the lens and see to it that one haptic is held with the glued IOL intraocular lens forceps in the left hand, the other haptic has to be left alone and somebody should be holding it till the first haptic is externalized and brought out through the 21-gauge sclerotomy. Once the one haptic is out, again you need an assistant. If you don't have an assistant, there are other methods also which I'll tell you shortly. Then using the handshake technique, you need 2 glued IOL forceps for this, and do that holding with the left hand, you do the handshake and bring the other haptic also through the 21-gauge sclerotomy, and once both the haptics are out, then you can relax, you can ask your assistant to leave it and see that the IOL is centered, and then you can leave, and then you can move on to tucking these haptics into the Chariot tunnel, which we call Chariot because Chariot is a friend from Germany who taught us that you to tuck the haptics into the intrascleral pockets, which we create using a 21-gauge needle. You can see that the IOL haptics are getting tucked now into the Chariot tunnels, which are created with a 21-gauge needle attached to a syringe, and you can see that the haptic is not sufficient, which is come outside. So what you have to do here is, you create one more sclerotomy, which is already there, and then go in, take the haptics once again inside, do a handshake technique, and this time bring this haptic through the other sclerotomy, which was created a little bit posteriorly. So once this haptic comes out, you can see that the lens is now more centered, more haptic has come out, and now sufficient haptic is come out, and do the retuck again using the same Chariot tunnel, or you can create another tunnel also in front of it or behind it, depending on wherever the haptic has been externalized. Using a 26 needle attached to a syringe, you can see me doing that. While tucking, take back the haptic and then tuck it again, and hold it very gently, otherwise the chances that you might break the haptic. Now once this has been done, you can bring the pupil back to normal normal small pupil, and then do a little bit of vitrectomy if there are any vitreous tags in the anterior chamber. And before you remove the trocar and cannula, which you can see in the upper right-hand corner, you need this trocar and cannula, an anterior chamber maintainer, to infuse the eye, because you cannot do gludial on a soft eye. So once this has been done, using the fibrinogen thrombin combination, glue the scleral flaps, and the remaining glue can also seal the remaining incision which you have created for a side port and through the main port, and you can see this results. See the pupil round, cornea is so clear, vision post-operatively is 20/20, sometimes even better than that. You can see this kind of results after the glued intraocular lens forceps. A few tricks which I can tell you is, before you start any surgery on glued intraocular lenses, you have to have either a trocar and cannula for infusing the eye, or you can have a Blumenthal's AC maintainer, because you don't want a soft eye when you're making the flaps or anything. And create the flaps before you make any entry into the eye. It is very important that these flaps have to be 180 degrees apart, because when you externalize the haptics, they have to be in a position in which when you tuck it in, the IOL should be centered very well. It should be in the center, and you should not have any problems when you externalize this haptics. If a little bit of haptic is come out, too much has come out or too less has come out, you can redo that and create a 20-gauge sclerotomy, either slightly anteriorly or slightly posteriorly. Really, and you can manage these lenses very well. Believe me, the results are unbelievable. Can we move on to my next video, please? So in between, if you have any doubts, you can stop me and ask me now itself, or whenever you want to ask me after my presentation, you can do that. Once again, this is my second video. This is a patient who is very, very dear to us. We get a lot of patients from Iraq nowadays. This patient was brought to us by one of our trainees from Iraq with him, and he said, you have to manage this case. Can you pause here for some time? This patient was already a pseudophakic, and what happens is he has developed Sommering rings. A PCO, a Sommering rings, which is very, very bad. When we dilate the pupil, we thought we are just doing a simple gludial in this case, but when we dilated the pupil, you saw that the ring is so dense there, and there is no way that we can do a gludial in this case without removing the Sommering ring. But remember that there are a lot of difficulties when removing the Sommering ring. You have to be very, very careful. They may not come in your vitrectomy cutter, and you have to use only a phaco probe. And when we use a phaco probe, before we do the gludial, there are chances that these Sommering rings might fall into the vitreous cavity, and they'll be sitting nicely on the retina. Then you have to do a posterior vitrectomy and go back and remove this pieces from the retina. So what we thought of, this is again, we started doing this recently. We started doing something called IOL scaffold. First, let me talk about this patient. This patient has posterior synechias. He had a posterior capsular rupture, because of which the surgeon might have put this intraocular lens into the ciliary sulcus. In addition, this patient has got a Sommering ring, which is very, very dense. So now we have to manage all these. These are multifactorial problems in this patient. So we have to manage this somehow. Now, what do we do in this case? We started doing something called an IOL scaffold. Now, when you have a problem, when you have a PCR, what you tend to do is, you stop your surgery, you do not panic, you have some more pieces inside the eye. When you want to remove this, there are other methods. You use something called a sheets glide, for which you might have to enlarge your phaco incision and then use a sheets glide to protect these things, or you use a OVD to stop all these pieces from going down. And instead of all that, we thought of doing, actually, Dr. Agarwal thought of doing this called an IOL scaffold, in which we implant the intraocular lens first, go behind and under the capsule, you implant the lens, and then tuck it in and use this intraocular lens as a lens scaffold, and then from anteriorly, you remove either the pieces which have been brought up from posteriorly, or they are still in the anterior chamber, or the surgeon had a posterior capsular end, some cortex and some pieces are still there. So implant the lens first, and the lens will form a glide for you, over which you can do a phacoemulsification or vitrectomy or anything, or you can open the wound and take off all the pieces so that those pieces do not fall back into the vitreous cavity. So remove the pause, please. So this is what remove the pause. Can we play the video? So now this horizontal diameter once again is more than the vertical diameter. In this case, if we do, can you pause for a minute? If you have a horizontal diameter more than the vertical diameter, if you do a glued intraocular lens, in this cases, the haptics which will come out will not be sufficient for you to tuck it, because the companies do not make glued IOL as yet for us, which are in overall in 14.5 millimeter in length. So we have to manage with whatever lenses we have. These are 3 pieces intraocular lenses used for glued IOL. So to manage that problem, instead of doing a horizontal glued IOL, you can make the flaps 12 o'clock and 6 o'clock, and we call it a vertical glued IOL. Does not matter. You have to sit temporarily and do this surgery. So anyway, if you are doing a temporal clear corneal incision for phacoemulsification, for the surgeon, this is not a issue or problem at all. So can you play it again, please? So in this case, we are doing a glued IOL. By now, you are clear of all the steps which we are doing. We are making a small incision using a 15-degree blade anteriorly, because this patient has also got a posterior capsular rent. Now, if we go and remove this sommering ring with a cutter, either we might chop off the iris, or this is not going to come out. So what do we do here? This is a lucky 7 sign in which when the lens comes out, it is curved like this. So hold the tip and externalize it very gently, leaving the second haptic outside. Now before we do that, we flex this haptic using a handshake technique. Hold somewhere in the middle. You need 2 glued IOL forceps in your tray every time you're doing a glued intraocular lens surgery, because sometimes one might be defective. You can have actually 3. Length of the haptic, once again here externalized, is not sufficient. So fresh 20 gauge sclerotomy is created anteriorly to the first one, but be careful, you do not hit the iris. You have to go slightly vertical, otherwise you will hit the iris. Now you have to re-internalize this haptic once again, using once again a handshake technique. The left hand is holding the haptic, and this time be careful, go into the anteriorly created sclerotomy, hold the tip once again, and externalize the haptic once again, and leave it there. Now we can see that the length of the haptic which has come out is sufficient for you to tuck it and create a center glued intraocular lens. A little bit, once again, when we are creating anteriorly is when we are doing that, you have actually hit the iris. You can see it is actually going into the iris. There is a hole in the iris which we have to manage later on. You can see that. This could have been helped, but it is already done, so we have to manage this somehow. The chariot tunnel is created. The first haptic is tucked. The second haptic also needs to be tucked. And once you finish doing that, the second sclerotomy should not be left alone. Anyway, we are going to put a glue, but still it is better for you to suture it and leave it there for later on to put glue to that. So now what has happened is, in the bargain, the pupil has become small. The sommering ring, which is so thick, is gone behind. So you have to dilate the pupil. So that's what you are seeing me doing that. Using the iris hooks, dilate the pupil and detach it and bring the sommering anteriorly in front of the IOL. Move it in front of the IOL. This IOL is going to act as a scaffold for you to remove the sommering ring, which is very thick, which will refuse to come through the cutter. So you have to use a phaco probe. Now you can you safely remove the iris hooks and go in with the phaco probe after enlarging the incision. Using very little phaco power or even an aspiration, you can remove this thickened ring very, very comfortably without letting it fall back. Now you have to manage this iris, which has been torn in the bargain when you created the second sclerotomy, which has gone slightly anteriorly. There is no problem. You can suture this iris and close that hole. This is a very easy technique. All of us are very familiar with how to suture the iris now. Now, once that has been done, then what is remaining is cut off these sutures and then close this hole. Stromal hydration is very important before you put the glue, and before you remove the trocar and cannula, which you are seeing in the upper left-hand corner, for vitreous infusion, before you remove it, the area has to be very dry. So for that, you have to stop the fluid, put a drop of air bubble into the anterior chamber, and then only go and remove the cannula, otherwise suddenly the eye will collapse. So now after removing that, you have to take your fibrinogen thrombin combination, the glue, which has to be a little warm, and put both the fluids onto the scleral flap and seal it. This glue can be used if you open a vial which is about 2 ml. Easily you can plan 4 to 5 glued intraocular lenses for that particular day, or even you can keep the glue for 24 hours, because this is coming from the Baxter company and is a little bit expensive. So you can reuse the glue in 2-3 surgeries, or even plan it in 2 days, the remaining surgeries, and do it. The glue is mainly to close the scleral flaps and close the so many things you have made on the cornea. You made the main port, you have put an AC maintainer, you have created a 15-degree 2-3 incisions in this case. A little bit can be used in all this incision to be closed, and you can see the results post-operatively. These patients go back very, very happily with a glued IOL. So this is what I wanted to show you this morning. Thank you very much for your patient hearing.
Just a question, Dr. Agarwal. Of course, in your iPad, you have the option of asking questions. You can just ask the questions, and I will get it here, so I can transfer the question to Dr. Agarwal. But I have a question personally. If a doctor who doesn't have any experience in posterior segment management,
Pardon me?
A doctor who doesn't have any experience, most of us don't mess up with the posterior segment. So still he can do this. Is it safe for him to do this?
Yeah, we are doing mainly only anterior vitrectomy in these cases. Yeah. Through the sclerotomy, you are going in and clearing only the anterior part of the vitreous. So any unexperienced in posterior segment surgeon also can do the glued intraocular lens surgery. There is no problem. It is very, very safe. Believe me, it is not difficult at all.
Okay, thank you.
Sorry, I don't have the pad. Just one question.
Yeah.
You are targeting 1.5 millimeter from the limbus for the sclerotomy, or less than?
No, just 1 millimeter.
1 millimeter.
Yes, 1 millimeter behind the limbus. Just more than sufficient. Sometimes you have to come anteriorly. You should not go more than 1 millimeter. According.
Otherwise, remember that there was a lot of discussion in the last discussion
Okay.
for 1 millimeter or 1.5 millimeter, and
I think he can answer you better.
Yeah.
It's a very good question. See, the problem what you're facing, as Dr. Athiya showed in the video, is the lenses are 13 millimeters. This is the real problem. Actually, I've talked to companies, actually all lenses, even in sulcus, if you have a sulcus also, if you want to put, it should be 14 millimeters, not 13 millimeters. But now we have 13 millimeters. Suppose you get a large eye, then you're coming anteriorly, because you need more haptic externalized. That's what where she showed is, she has come posterior, 1.5, then she feels, okay, it's less haptic externalized, in which case you come more anteriorly. The drawback in that is, you might hit the iris as she hit. So you might have to do a mechanical suturing. But issue is you should have enough haptic externalized to tuck. Keep that fact in mind, that's all.
Apart from that, the power of the lens that you are
Same.
Same.
for the sulcus.
Same. No. Same as the IOL normal. Because normally you put it where the PC IOL is, so I don't change the power.
Yeah, we know that. Oh, I think that Ahmed showed me that.
But this would go somewhere
but
in the
if you have entered capsule and you put it in the sulcus, this is another story. But if you put it sutured or
But this is going in where the normal,
it's
normal
the
IOL
position
is.
of the regular IOL.
Yeah.
So that's why you don't alter the power. Unfortunately, Dr. Francesco Carones had an early flight, so he wouldn't be here. And Dr. Ahmed Assaf had a family business, emergency that he left. So I will just present my presentation. So I will try to convince you that the artisan IOL is actually a very good option for treating aphakia or treating or managing the weak zonules. We know that the artisan lens or this iris claw lens was invented very like 50 or 60 years back by Dr. A-1st. Although it has been altered by the company to the artisan aphakia lens. The early version of Dr. A-1st was a plain one that can have pupillary block. Now the new lens has a vote to prevent this kind of pupillary block. It was, as I told you, it was in the early 70s that Dr. Wurst did it. Now the artisan lens has an overall diameter of 8.5 millimeter and optic zone of 5 millimeter, and it's supported in the mid-iris periphery by very flexible close. This is actually very flexible that it's very hard to break. It is made of PMMA. The powers ranges from +2 to +30. It has one diopter in the infrequent powers, but in the frequent powers, the powers is in 0.5 diopter increment. It's fixated, as we said, in the mid-periphery of the iris, and it's centered, most of us center it on the pupil, over the pupil itself. The fixation points of these lenses are located in a virtually immobile part of the iris, which is the mid-periphery. The mid-periphery of the iris is not mobile. It doesn't, when we dilate the pupil, this area maybe will come, but it will not move. And the iris bridges that is put in the enclavation itself protects the PMMA part of the close to be touching the cornea. So it's safe for the cornea if we are afraid to touch the cornea. The fixation concept permits the position of the artisan aphakia IOL in the optical axis of the eye and permits excellent centration. Of course, we can put it anywhere. Actually, if you have eccentric, like one of these videos that I will present, has an eccentric pupil, it can be put on the eccentric pupil. If you want to put it on the optical axis, it can be put on the, it's very versatile. And the two diametric opplers, it's 180-degree opposed close, secure the stable fixation of the iris to the iris and prevent the risk of the post-operative decentration. The system is extremely versatile. It may be fixated horizontally, obliquely, and it is independent on the overall size of the eye. And even it can be inserted in the posterior chamber by reverse enclavation. How about if we want to dilate with this kind of lens? This doesn't even interfere with the dilatation. As we see here, the patient is fully dilated and still the lens didn't move. So if a patient has some retinal problem, still we can see the retina. And it can constrict in the pupillary reflex, it's just normal. There is no, in fluorescein angiography, as is a study done by Dr. Strobel and Isaac, it has been shown that there is no leakage of the iris vessels, even in the enclavation area. Only a few cases had an atrophy in the area of the fixation and had been reported by, actually, and last week we had one that we had repositioned to put it in another version part of the iris. It has an advantage that it doesn't need any suturing. So no suturing of the lens. Of course, we have to suture the incision if you do incision. And although now I have a couple of cases that I've done actually a scleral tunnel, just like we do the small incision ECC. We have done the scleral tunnel and advanced the lens through the scleral tunnel and put it in place. And this didn't need any suturing, so it's even this way it's even astigmatic friendly. There is no angle concern. This doesn't depend on the angle. So if you have posterior angle problem, posterior anisanikia, or whatever problem, you don't worry about this with this lens. Unlike the Kelman multiflex, it has a safe distance from the cornea endothelium. So the safe clearance, so we said about the dilatation and the clearance. Actually, but we still have to have 3 millimeter deep anterior chamber at least to have this lens put. And there is a study here I will present that will show how the endothelial loss will happen if this one will turn. I hope it will turn. No. Second. Can I have the second one? Yeah. No, previous. Is this not working anymore? That's it. Yep. Okay. So, what's going on? Well, I want to go back. Anyway, so it's universal. The advantage is that universal lens. You can put it in the ECCE. You can, with phaco, you can put it in aphakia. You can put it in primary cases. You can put it in secondary cases, and you don't have to worry about the white measurement. You can put it in any corneal diameter, except of course microphthalmia. It still has disadvantages. It requires some surgical skills, especially because you're handling the lens. You should hold it with one hand and enclavate, and then you have to do the same with the reverse hands. So it needs some experience, but actually the curving learning curve is not that high. It requires the incision, which is 5.4, but I told you about this scleral tunnel, and this can help you eliminate this kind of big incisions that can cause lots of astigmatism. This is some study done by Dr. Tahzib, and he showed that the mean endothelial loss with these lenses was, in 10 years, was 8.86%. If you compare this to the 0.6% that happens in everybody, so in everybody in 10 years will have 6% endothelial loss, and this one has 8.8 or nearly 9%. So it's not that big deal. You don't have to worry much about the endothelial loss with this kind of lens. Although it's an anterior chamber IOL, and this, if you compare to the Kelman, this is more endothelial friendly IOL. In the study, in a study published in 2005 of 16 eyes after 36 months, the artisan aphakic IOL was safe and effective option for the eyes without the capsular support. This study was done by Gould et al. So the indication, you can put it in primary cases in any poor capsular zones, like in Marfan syndrome, in secondary implantation aphakia, in IOL exchange, if you have problem with the primary IOL and you want to exchange it, this is a very good option, and you don't have to worry about uveitis, glaucoma, hyphema syndrome. It still has a contraindication in recurrent or chronic iritis. In corneal dystrophy, you shouldn't put it in corneal dystrophy. In diabetic retinopathy, because we don't know if this patient gonna have any rubiosis iridis or anything like this, which is a contraindication for these cases. Acute inflammations, severe iris atrophy, because then you don't have to anywhere. So essential iris atrophy, we cannot put this. Eccentric, very eccentric pupil, we cannot put this. Uncontrolled chronic glaucoma. If we have vitreous loss with choroidal hemorrhage during the surgery, it's better to avoid putting any lens at all. So the surgical technique is you have to remove, of course, the vitreous, like any anterior chamber IOL, and the pupil should be smaller than 6 millimeters to have place to put the enclavate the lens, and the AC should be deeper than 3 millimeters. And then we do 5.4 or 5.5 incision, and we put the cohesive viscoelastic, center the lens, put the lens, center it, and then enclavate in the mid-periphery according to whatever position you want to put it in. So the average time of this surgery is about, if you want to put the lens, is about 10 minutes. What's the average of, Dr. Agarwal, what's the average of the glued IOL, the time?
10 minutes maximum? 5 to 6. Yeah. He can do it in 5 to 6 minutes.
Okay. Because if I'm going to suture IOL, it takes like 45 minutes. So, yeah, so it takes like 45 minutes if I'm going to suture the lens. So this is, none of these videos are mine. Actually, I got it from the media. This is just a regular surgery. We'll show you how to put the lens. You just make the incision, put it over the iris. We put viscoelastic in the beginning, and then hold the lens with one forceps here, and then enclavate with the other hand, and then reverse the hands with the right hand, hold the, and this is the most difficult part, is how to handle both hands at the same time. This is another case which has subluxated IOL. Same incision was done. And then the IOL was extracted. And anterior vitrectomy was done. And then they put regular IOL. I will just show you more interesting cases. This is a case with penetration caloplasty. Even with penetration caloplasty, you can do this lens after removing the vitreous. And this lens is a historic lens with 3 haptics. After extraction, you just can put, enclavate the lens. And I think at the time with PKP, it's much easier than putting it with the cornea on. But of course, we have to have a very good vitrectomy. Just put it on and put viscoelastic over it, and then suture. Can you go back for this one? No. Okay, next. This is a Peters anomaly, and the surgeon did keratoplasty and removed the lens matter, the adhesions and the lens matter. And even this kid, they put the artisan IOL. And I think this couldn't be done otherwise. They just remove the synechia from the lens, and then they cut the lens, just cut the lens. And this is a case just to show how if the pupil is eccentric, this is post-PKP and DLK, whatever, and the lens, the IOL was, the pupil was eccentric, and even you can put the lens at the pupil, on the pupil, regardless to the cornea, regardless to the visual axis, so it will have better function. This one you can skip it. And thank you very much for, I hope I'm convincing you about the artisan IOL. So, now we want you to vote about, we have 2 questions for me. Artisan lens is uncomplicated surgery. Is there any cases of iris atrophy in the long term? And it might induce decentration. Yes, there are some reports of iris atrophy in the literature, but the good thing about it is you can just rotate the lens anywhere else and put the lens in another position. Artisan lens, this is the same. Good day, sir. What's the age range you can put the artisan in? Kids can do it. The elderly can do it. Endothelial count should be done in the elderly cases and in the in post-PKP. But any age, unless the eye is microphthalmic. Okay, that's it. So we'll shift to the other session. So we can vote again for, can we put the questions and vote again? Yeah. So what would you prefer? Anterior chamber IOL, iris glow IOL, sulcus fixated IOL, or others? I took only a small part of the anterior chamber IOL, but I take any part of Dr. Agarwal. So Dr. Agarwal wins. So we'll go to the next case, next session. We'll start with, this is not today. with managing narrow pupil IOL. So maybe Dr. Amar will just give us his experience in managing the narrow pupil IOL.
It's not a narrow pupil, but we can cover it up. It's on, I think, complications. Doesn't matter. Can I have the first video, please? At the outset, I'd like to thank once again Mohamed, Tamer, Ala, and the rest of the Maghrabi group for inviting me and Dr. Athiya here. So let's see some videos, and let's see how to manage various problems. Now, the first thing, if you see here, in this case, this was the brown cataract. Now, you can see I'm having difficulty in rotation. When I'm having difficulty in rotation, I should have understood there's a problem. But I am a bad surgeon, so look at that, gone. The moment I should have realized when I was having difficulty, I should have stopped. I did not. I went for phaco, and boom, nucleus down. Now, at this stage, you can try a posterior assisted levitation. First of all, suture the wound. Once I have sutured that wound, I'm trying posterior assisted levitation. Look at that from the side. I'm trying to lift it up. It is not working. When you don't see, stop. So I shifted to 3-port vitrectomy. And you can see here, I'm doing my vitrectomy. Always start from the anterior route. So I'm clearing up the anterior vitrectomy, clearing up the cortex. Now I will go posteriorly, and you can see doing a vitrectomy, and that nucleus is lying on the retina. Now, once you have done that, take out one trocar. See, I'm taking out the trocar. I'll extend the incision a little bit. Now, inside the vitreous, you have fluid. I take the sleeveless phaco needle, keep it there. On suction, just bring it up. Watch now. I'm just, pause please. Now look, pause it. Now you can see once I have brought it up, I will embed it a little bit inside. Once it gets embedded inside, as you can see, now it's embedded. Now I know this piece cannot go anywhere. Play the video. Now I will tilt it anteriorly, bring this nucleus above the iris. Once I have brought it above the iris, as you can see, I'm using my 2 hands, I am a bit safe. Now the question comes, pause the video. What next? How do I remove this? I can extend the incision and remove it, but then the problem then comes, I have lost all my advantages of a 3mm incision. Second problem is, if I phaco now, a portion of that piece will go down. Play the video, please. So what I'm going to do is a technique which we started called the scaffold technique. When this technique of bringing the nucleus up is called SPAL, or sleeveless phaco tip assisted levitation, which was published in the BGO recently. And now the next step is to bring this nucleus out. So I'm taking this IOL, and you can see this is the lucky 7 sign. Pause, please. In which you can see a small portion of that haptic is out of the cartridge. The longer portion of the haptic is inside the cartridge. This word was coined by Tom Oting from Iowa. Play, please. Now what I'm going to do is I'm going to put this IOL under the nucleus above the iris. In other words, I am going to create our own posterior capsule. So you can see one haptic above the iris, one haptic is out. You can keep the other haptic out. You can keep both haptics above the iris. You can put both haptics into the sulcus if you have a good sulcus present. Inject some viscoelastic. But now you can see I can now phacoemulsify it. Play, please. Pause for a second. Now you can see there is an air pump also working. So I get a deeper chamber, but no fear of my nucleus going down. Play, please. Now you can see I will emulsify these fragments slowly and steadily, and you can see that capsule is working like a nice scaffold. The word scaffold is from a Latin word, scaphandulus, meaning a platform. So it's giving me a platform to play with. It is also compartmentalized the eye. so that you don't have that vitreous coming anteriorly, because this compartmentalization has already occurred, and you can see my nucleus gone out. I have an air pump working, remember, so I get a deeper chamber than normal, put a suture, but remember my IOL now is above the iris. So I go inside, because some cortex might be there, that removing the cortex is very easy. So I go in with my vitrectomy, 3-port vitrectomy, clear up all the cortex, small pieces there, they can all be removed very easily because nucleus has also gone totally. See the disc, you can see the fovea in place there, small fragment of cortex there. I'm just staying above that and I will aspirate it. And you can see there that last piece gone. Once this is clear, now my question is, how do I put with the IOL inside? At this stage, I do not know where my rhexis margin is and how much it is. So dilate. Use iris hooks and dilate the pupil. Once my pupil is dilated, I can assess, does it need glued IOL or can I put it in the sulcus? In this case, I have enough support. So I'm going to just put it into the sulcus. Once it's there, I will remove the iris hooks and finish off this case. So you can see there, iris hooks removed and the case is over, stromal hydration done, and that basically will complete this particular case. This is how the patient looks at the end of surgery. And now the question comes, post-op day 1, little bit of SK which you expect in such worst case scenarios, but 2 weeks post-op, you can see the patient has improved to 20/30. Can I have the next video, please? So this technique is called the IOL scaffold. It has got published also in the Ophthalmology Journal of the American Academy of Ophthalmology. Now let's look at the second problem which we face, as Dr. Athiya talked to you on sommering rings. Now you see in this case, pause please. Now where is sommering ring a problem? Sommering ring basically means the anterior and the posterior capsule are fused in some areas and a ring of a sommering ring is being created. If you leave it behind, 1, it can fall down, 2, it can dislodge the IOL or tilt an IOL. 3rd, it can produce inflammation. You cannot remove them with vitrectomy probe, as Dr. Athiya showed. So she showed a good Mills and Boone lovely picture of sommering ring case. I thought I should show you a Frankenstein picture of a sommering ring case. So let's see this. Now you see I've made my scleral flaps. Play please. I'm going in for doing my vitrectomy, and suddenly you see behind the iris, which is not very clear now, I'll see a sommering ring is still there. Now at this time, the mistake I've done is I'm trying to break this synechiae, and in the mistake in trying to break my synechiae there, you can see my sommering ring gets dislodged. Look at that. But still, I'm okay. If I do a glued IOL scaffold, I can remove it nicely the way Dr. Athiya showed. So I go in and do it. Now watch it. Play. Pause it for a minute. Now watch. I am struggling. During this video, you watch this portion which is on your left. I am struggling to pass my forceps inside and I'm not understanding why. Play please. And while I'm struggling, my sommering ring is getting dislodged more and more. I passed it inside. I have caught my haptic, but now watch. I'm asking my assistant to inject the lens. Now I pull out my haptic to externalize it. And you see my ring in this manipulation has got dislodged even more. Now, to my dismay, my haptic is missed. So now what I have to do is I have to go back in again. Now when I'm going back in again I'm struggling to pass the forceps inside on the left hand side. Now once I go in again, I'm going to do a handshake technique. So you can see that I'm catching the haptic because I need to grasp the tip of the haptic. From the other side, I'm going in from the other side, catching the forceps, catching the haptic with the forceps, trying to catch the tip of the haptic to externalize, and look at this, my ring is gone. In the bargain, my sommering ring has gone down. So now, this, as I told you, is a Frankenstein picture. Now I go in for my trailing haptic, and as you see, I'm shifting it from one hand to the other, catching the tip of the haptic, externalizing it with a handshake technique. Now once I have got both haptics through, you will notice, pause the video. Look at the amount of haptic externalized. It is less. If you have that much haptic externalized only, what will happen is this lens might dislodge post-operatively. Play, please. So again, I have to come anteriorly, make a fresh sclerotomy, take this haptic, pass it into the vitreous back, re-internalize, again do the handshake technique, come from the anterior root, catch the haptic tip, and now again externalize. So in other words, I have re-internalized and re-externalized the haptic. Now pause, please. Now look at the amount of haptic externalized on your right. Compare it to what it was just a few seconds back, and you will see the difference. Play. Now you see I'm doing the same on the other side. Now watch the mistake. I told you my forceps is not going in through this side, and look at that. I'm struggling. I've caught the haptic, and again notice I'm catching the tip of the haptic, but now I realize my mistake during the whole surgery was, pause please, in the left side I was using a 20 gauge forceps. In the right side I was using a 23 gauge forceps, so I'm track. But the mistake is when you have a 20 gauge opening, you cannot use a 20 gauge forceps. You have to have a smaller forceps than that. And that was a mistake where I was struggling in. Play please. Now, once I have done that, I create my Gabor Chariot's pocket. As Dr. Athiya said about Gabor, who's such a brilliant surgeon and a great human being also. And you can see on the other side also, I have done that. The posterior sclerotomy, I prefer to suture because I don't want to keep it open, though I'm going to glue it down. But remember, case not over because the Sommering ring is down there. So I'm going to do a vitrectomy. Once I've done vitrectomy, I'm going to catch the Sommering ring. Now my issue is to bring this anteriorly. The patient has an iridectomy on the top, so using that space, I'm going to bring it anteriorly and put it above the IOL. Once I've put it above the IOL, I'm safe. Now I can go in with my phaco probe, and now I'm doing a glued IOL scaffold, because the glued IOL is now acting like a scaffold. Once I have done that, my next step is to do a little bit more of vitrectomy. But remember, I have an iridectomy already there, so when I'm inside there, I might as well suture the iridectomy. So what I'm going to do is I'm going to put the mecanal suture, make that pupil smaller, so that the patient will be more comfortable post-operatively. So you can see here, this video which I wanted to show you was a case to show you the other side of Sommering ring disaster which can happen, so that you see a myriad of pictures which Dr. Athiya showed a nice case, and I'm showing you a real disaster case. In the end, put the fibrin glue and touch wood, paradise regained. So you can see how the patient looks at the end of surgery. Can I have the next third video, please?
I have a few questions for you.
Yes,
first.
just,
So,
yeah.
One question is, in the first video, too much maneuvers in the anterior chamber wouldn't affect the endothelium if you
Too much? Too much?
if you get the nucleus in the anterior chamber and then start.
No. Can you repeat the question, sir? Or too much nucleus in the anterior chamber, yeah?
So it wouldn't affect the endothelium of the anterior chamber?
That's why I mentioned to you, if you have a hard brown cataract, extend the incision and bring it out. But if you have a piece like that, what you can do is, there are two alternatives. The one which I showed you was putting the IOL under the iris, but I'm using an air pump. So I get a deeper chamber. The second alternative, which you can do is, do a glued IOL under the cataract. That way, what happens is the nucleus goes down, and then you get even a deeper chamber. So both the methods you can do. Third alternative, as you said, you can always extend the incision. But for my cases, I never extend by and large. I finish it off like this.
And there was another question. What was the difficulty in the first case? What made it go like this?
What was the difficulty in?
Why the question is?
Why did the nucleus go down?
Yeah.
Well, I think, to be honest to you, there must have been something wrong, because when I did my hydrodissection, I might have ruptured the capsule perhaps, because when I went for rotation, it was not rotating. And without doing any phaco, when I just went it with a phaco needle, it just dropped down in a second. So must have been some mistake for me, which I have done or created during my hydrodissection.
And a question for me actually, how big nucleus can you leave it in safely in the procedure. But would you?
Oh, I would never leave.
You did.
Oh, I'd never leave. No, no way. I would never even leave cortex behind. I tell you what, if you leave cortex or nucleus behind, it is a complication. Let's be real. One, it will produce inflammation, irritation. Tomorrow you will leave a nucleus behind and it goes to your neighboring doctor. The next thing he says, nucleus is left behind. And if that goes for a medical legal case, nobody will be able to save the doctor because there's a nucleus is left behind. But one more point which I need to stress to all of you, and let's understand this point very clearly. You have a nucleus in the AC. I'm putting an IOL above the iris and I'm emulsifying. Now I began to realize if it's a large piece, as the question with the person who asked you the question in the iPad is a very good question, can it damage my endothelium? And we have sent our results for this also, but it does not, but because of the air pump. But another way is, suppose you have an IOL nucleus here, iris here, do a glued IOL. Now when you do glued IOL, the IOL comes down. So the nucleus comes down. I get more space in the anterior chamber to play with. So this is where glued IOL scaffold works. Okay, can we have the third video, please? Now let's look at this. I showed you yesterday some good, again, Mills and Moon pictures on PDEC with the cataract complications. So I'm going to show you now a longest day, part 5. Basically, you know, you've seen Iron Man 1, Iron Man 2, Iron Man 3, like that. This longest day basically is a good terminology to cover my deficiencies as a surgeon. So it actually shows how bad a surgeon I am. You can see now I'm doing the PDEC graph, which you all know about here. And I've created this PDEC lenticule now. Once I've got the graft, I will now keep it in the MK medium. Now pause, please. Now if you see this patient, the cornea is so bad here. Play. I'm taking off the epithelium, but you will notice this patient has an AC IOL implanted, which has created this problem. So I'm created my scleral flaps, I'm doing my vitrectomy, and now I'm making my scleral tunnel because the ACIL has to come out. But you'll notice now, see that shine, pause please. See something moving in the vitreous cavity. The surgeon had dropped the nucleus, left it behind, put the ACIOL and closed up the case. Now what I'm going to do is play. I'm going to now take out that ACIOL. So what I'm going to do now is play. I know this ACIOL is now stuck to the iris. So what I'm going to do is I'm going to chop the haptics of that ACIOL so that once I chop the haptics, I'll be able to release the IOL from the iris and bring it out. So now I'm going to grab that IOL and I should bring that IOL out of that eye. So you can see I'm holding with the forceps, but to my dismay, it rotates and drops. Pause. Now you see the first surgeon dropped the nucleus. I also dropped the IOL now. So if you have not seen rock and roll, watch now. Play. Now you see there will be rock and roll. Nucleus and IOL are dancing in the vitreous cavity. See? Nucleus, IOL. Nucleus, IOL. Pause. At this stage, there's one thing which you should do. Start praying. So I'm praying now and hoping everything becomes all right. And to my luck, the nucleus comes anteriorly. And you see now, it's stuck there. Play, please. Now at this stage, I am not releasing my forceps because I am not worried about the endothelium. I don't want this nucleus going down anyway. And now I go in and grab something shining. And what I find? A broken haptic, the one which I cut. So why I go in now inside with my vectis, and now I'm going to remove this nucleus. IOL is still inside, don't forget. So once that's down, I go in with my vitrectomy, I do a vitrectomy, clear it up, and a trick which one of my doctors taught me, Dr. Ashwin, was to use the extrusion cannula to lift the IOLs. See that, using suction I catched it. This has also been published in the BGO just now. Shift to a forceps, grab that broken haptic. Once my broken haptic has been caught, I will now externalize or explant that IOL. I'm using a rod with my left hand to prevent that IOL from falling down. Once that has come out, now I do a glued IOL. Once I do a glued IOL, this one you know now very well, how to do the glued IOL technique. You have externalized both the haptics. The advantage in the glued IOL is there is no pseudophacodonesis, which makes a huge difference to the post-operative results compared to any iris sutured, iris claw, or a sutured scleral fixated or an AC IOL. Now I create the Gabor-Chariot's pocket, tuck the haptics inside those tunnels now. Case not over. We have to work on the endothelium also. So as I told you yesterday, I will do a pupilloplasty to make the pupil smaller. Once my pupil gets smaller, then I will now see I've got a good round pupil. I now take off the endothelium. Little bit of endothelium, the first surgeon removed. Remaining endothelium, I removed with my bad surgery. The remaining 10% which is left, now I'm going to remove. Once my endothelium has come off, then I will take my graft, load it in the injector, inject it inside, and then unroll the graft. So you can see the injector injecting the graft inside. Once my graft is in place, then the game is simple. I just go in with the air, inject that air, tamponade that thing, and you'll see how the graft is looking when it's attached. Now apply the glue, seal everything down. Let's see how this patient behaved post-operatively, and you can see here on table how the patient looks. And now the first day post-op, you can see the eye much better compared to what it was, and that's the pre and the post. Can we have the last video, please? The last video which I thought I will show you, and this is my last presentation for Dr. Athiya and me in this lovely conference. And I want to really tell you people the amount of lovely time we've had, though it was a short trip, but it's a very nice time which we have had. Now this particular patient was a one-eyed patient, okay, and the patient had an injury. I can't see what's going on, to be honest to you, but I noticed something blue there under the conjunctiva. The patient had an injury, the IOL has come out and it's lying under the conjunctiva, and this, ladies and gentlemen, is a pseudo-phacocele. Something brown is with it also, so I don't know what this brown structure is. We'll analyze it later. Thanks. Now once I've done that, I remove the IOL. Once my IOL has come out, thank you very much, sir. Once the IOL has come out, I want to know from where that IOL has come. So I'm catching the recti to see is there any peripheral perforation. There doesn't appear to be. And I realize the patient had a scleral tunnel wound which has opened. And through that, because of the trauma and the injury, the IOL has just come out. And you can see that's where it is. So I realize this patient will definitely need a glued IOL. So rather than doing anything, first fix an AC maintain. I'm not fixing a trocar because I really don't know my anatomy very clearly in this stage, in this eye. Make my scleral flaps, suture up the scleral wound which is there. Once I made my flaps, and I'm going to suture up the scleral wound so that I have a good eye present, I'm going to take off that epithelium. To be honest, I do not still know what's happening inside the eye. I can't see. So I say, let me go inside and clear up what's going on. So now you can see, I'm going in with my vitrectomy probe. I'm going to clear up everything, and I see full blood inside. Once the blood is there, I'm going to do a vitrectomy, clearing up everything, going near the disc, the macula, and you can see the amount of vitreous hemorrhage which is there, but gradually and steadily notice the disc coming into picture there. So you have the disc, you have the fovea, everything coming into picture. Now pause. Now see. It's clearer. But what I see, that brown structure was the iris. Because of the trauma, the iris came. So now I have got an aphakia with aniridia. Play, please. So now what do? I'm stuck. So I use an aniridic IOL. In other words, this is a single piece, non-foldable IOL, which has got an artificial iris with it. The only problem in this is, since it is one piece, it's tricky, and you notice the eyelet. These are actually kept for sutures. So it's a bit tricky to handle, but I have no other choice because this is the only lenses available in the market at present. Catch one haptic, externalize it, catch the second haptic, externalize the second. Again, you have to be very careful when you do both. Handling, suture up the scleral wound because it's a large incision. These are large lenses, and remember they are non-foldable. Once you have done that, the next step is to take the Gabor-Chariot's needle, create that pocket with a 26 gauge needle, tuck the haptics inside. In other words, ladies and gentlemen, what am I doing? I am creating an aneridic glued IOL. So once both haptics are tucked, I will now inject some air in the chamber so that there will be no hypotony when I remove the fluid. Because obviously when you apply the glue, you don't need fluid in that eye. Take out the two trocar cannulas, take off the AC maintainer, do some stromal hydration, inject air in the chamber, apply the glue, seal everything, and create the aneridic glued IOL. Now let's see how this patient behaved at the end of the day, because that's very important in life for us to analyze how these patients do. So you can see there, this is how the patient is looking end of the day, 2 days post-op, 1 week post-op, and now you will see, pause the video please, 1 month post-op. Remember, this was a one-eyed patient, aneridic glued IOL. Play please. The last clipping which I thought I will show you is of a lady. Pause. She was a lady. Her husband punched her. When the husband punched her, the crystalline lens came through and through out under the conjunctiva, and what you see here is a phacoseal. Play please. Now you can see, I'm going to do a removal of that conjunctiva cutting, and you can see the crystalline lens coming out, which is lying under the conjunctiva. Do a vitrectomy, do a glued IOL, and finish off this case. Pause please. Remember, I told you her husband punched her, and because of that, she was anyway a one-eyed lady, and she eventually came up to 20/20. She came to my consultation chamber, and I was very happy seeing her. And when she sat on the chamber, she told me, bah, 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 bah. So I looked at her and I said, what bah, 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 bah? What are you shouting for? No, doctor, you see, I am not happy at all. That day I understood why her husband punched her. And I tell you, ladies and gentlemen, I would have punched her myself if she did not have a glued IOL inside. Thank you very much. Have a great day. And thanks for the lovely conference. Thank you very much.
Thank you very much, Dr. Amar. Actually, thank you for showing us horror movies. And we should have made notification that anybody with heart attack shouldn't attend here. So thank you very much for attending. Thank you very much. So now we'll have voting for if you have a pupil, a small pupil, what would you do? Would you do sphincterotomy? Would you use iris hooks? Or would you use iris stretching rings? So we'll have the voting. No, this was this. Okay, there it is.
Ahmed, can I ask a question?
Sure.
I have a question for you, sir.
Can you have mic here?
Please ask. Yeah, sure. I'm a retinal surgeon. I was interested to attend this session to hear about the suppression of failure, because we do these cases a lot.
Yes, from the enemy side.
Yes, so I have a comment for you. First of all, you are obviously you're an excellent surgeon, even a posterior segment surgeon, not just an anterior segment surgeon. But I have two comments. For the first video that you showed when you had a dropped nucleus at the back of the eye, which can happen to any surgeon. And you showed things that I think you're asking too much from the anterior segment surgeon to do, that probably not every anterior segment has the experience to go inside the eye and bring a hard nucleus sitting on the macula. And at the same time, from my point of view as a retinal surgeon, you did a little bit less than you are expected to do. So what we always recommend for anterior segment surgeons, if you have a dropped nucleus and you just don't worry about what's dropped at the back. You just make sure you have an anterior capsule, you put an IOL, put a suture, and then we do the whole vitrectomy, the fragmentation at the back of the eye, no stress on the cornea, In addition, of course, you're putting an IOL, which is on the pupil. The patient already has a posterior capsular tear. You're doing your phaco in the anterior segment. You also have the chance of dropping both the nucleus and the IOL at the back of the eye. So what I'm saying is that you're an excellent surgeon, but I don't think that every anterior segment surgeon is capable of doing what you're doing. So what I recommend for anterior segment surgeons is just leave the nucleus, do a good anterior vitrectomy, put an IOL, 3-piece IOL in the sulcus, and let the retinal surgeon do the job at the back. That's the first comment. The second comment is when you're doing your glued spherical fixation IOL, which is a great technique. But what I noticed that in some of those cases, there was not enough anterior vitrectomy with vitreous-based shaving. And I see that you go inside with your forceps several times, whether with the first sclerotomy or even with the second sclerotomy, you go even anteriorly. So playing with this area, there's the vitreous base. You can easily create a tear that will not have a problem during surgery. But I expect probably few cases of yours develop retinal detachment later on. So I think there are some breaks that happen at the vitreous base. So what I would recommend for this technique, it's a beautiful technique, is that you should have a 3-port vitrectomy, a good vitreous base shaving with indentation so that you clean completely what is behind the iris of vitreous. And you can see the periphery of the retina quite well, and then do your glued IOL. So these are my 2 comments.
Good. 2 questions, very good. Comments are there. Number 1, when you talk of a drop nucleus, once it goes posterior, because I'm a trained retina person also, so I'm doing it. But I don't recommend this for an anterior segment surgeon at all. When we are talking of a lens lying on the retina, it has to be done obviously by a trained retinal surgeon. But yes, if it is subluxated, I don't think it has to be shifted to a retina surgeon. An anterior segment surgeon can bring it up anteriorly with the PAL technique, but once it goes behind, 100% it should be done by a retina surgeon. But the point also which you made that if you are an anterior segment, you have dropped down, just put an IOL inside, close up, refer it to a retina person, which I think is a correct technique to do. In our system, what the system is, everything is under one roof. You know, so if someone has dropped a nucleus or somebody has referred us a nucleus, we finish it all off one shot because as I told you, I'm a retina person also. But otherwise, 100%, just close up the case. Even if you don't put an IOL inside, the retina person can also put an IOL inside, or you can give him a call and ask him, shall I put the IOL? If he's comfortable with that, put the IOL in the sulcus and close up the case and refer it to him. 100%, you're right there. Now let's talk to the second story. Does an anterior segment, does he have to go ahead and do a thorough vitrectomy? That's the next question. If he's doing a simple glued IOL aphakic person, the answer still is no to me. An anterior segment surgeon can still do a glued IOL. Because here, let's understand some concepts here. Every phaco machine today has got very good vitrectomy setups. The only point is, whichever phaco machine you have, ask your company people, is it 20 gauge vitrectomy or 23 gauge vitrectomy? Let's take Infinity as an example. They'll have 23 gauge vitrectomy. There's no problem. When you make your sclerotomy, you can go ahead and do vitrectomy through that. You can use triamcinolone to check if there's any vitreous in the anterior segment area there to check whether you have cleared it up. But if by chance your phaco machine has got a 20 gauge vitrectomy, very simple way is, again, don't refer it to somebody. You can still do it yourself. Do the vitrectomy through the corneal route, because that is too thick a probe. But if you're stuck with a phaco machine and your hospital or the setup which you're working in does not allow you to move or upgrade your machine higher, you can do it still with a simple 20 gauge vitrectomy. So now the question comes, do I need to go to the posterior vitrectomy thoroughly and doing it? My personal viewpoint is, if this is not a drop or something like that and you're simple doing an aphakic, you don't need to do that. Yes, 100% post-operatively if you want, check for the peripheral retina always for any breaks which you have post-operatively, which any anterior segment surgeon should be able to do. Coming on the data on the retinal detachments which we have got, we do a lot of glued IOLs. We do perhaps about, I don't know, but must be doing huge numbers of glued IOLs every month, and the data has been published already. If you see the latest ophthalmology journal of the January issue, our article on the glued IOL is there, so you'll get it, but the percentage is so less. Now the question comes, why is it less? The reason is very simple, which I feel is, the lens is very stable. So when there is no pseudophacodonesis, there's no endophthalmodonesis, so there's no movement. Now if you all have these phones, which are these iPhones, a simple trick which I tell all of you is, download an app It's called slow-mo, S-L-O-M-O. Now, normal these videos which you are seeing of mine show 25 frames per second. Now, if you have an iPhone 5, it will download, it's free. Okay, it downloads at 125 frames per second. An iPhone 6, which Allah has, and he's going to donate to all of you after this conference, is an iPhone 6. So all of you be ready for that. Okay, it will give you he's hiding his phone for me. It's 250 frames per second. Now, you know, these phones come with adapters which are very cheap, which can fix onto your slit lamp. Take a video. If you put any lens of your choice, ACIOL, anything, or a glued IOL, and take a video and you will check the movement of the lens, and you'll see, I've sent it to JCRS, it's under review right now, you'll see movement of that IOL. So the answer for glued IOL success is primarily because of the pseudophacodonesis not being present. Thank you very much.
Thank you very much. Thank you very much, Sharif. So for the question, I think 2/3 would use the iris hooks and 1/3 would use the iris stretching rings. And Dr. Tjia will give us his experience in managing the small pupil.
Dear Chairman, ladies and gentlemen, let's go to a subject which luckily is a little bit less complicated, but more frequent, and that is narrow pupil management. Within the topic, I do not have any financial interest. So we have all these options with narrow pupils. Just go through the narrow pupil, which is very dependent on your level of expertise and your skills. You know, iridotomies, pupil stretching, I missed that in the list for the audience vote, which is still very widely employed. Of course, iris hooks and rings. When you have a medium narrow, this is what I was fearing. So this was supposed to be a video. No, it's not running. Yesterday I checked all the videos a couple of times, and finally they played. This morning, I just asked, wow, you're kidding me. Oh, thank you so much. So with a medium narrow pupil, which is very, very frequent, what you I am slow, but not that slow. Did I do something? No? Well, anyway, this video is just a regular video, so let's skip to the next one. And
Can you just try to play it again, please?
Oh.
No, you go forward. You just go back and...
No, it's just okay, yeah. I'm just trying to remain calm and zen. And for people who know me, I'm outperforming myself largely by staying calm. The pupil stretch, as I said, is still very widely employed, and you can obtain a 5mm pupil in cases where you do not have a floppy iris. And dependent on your skills, this is a perfect solution. Again, if there is any sign of a floppy iris, this is a disaster scenario. So I'm not talking about IFIS, because that's a totally different management strategy. So if you do mechanical pupil stretch, it's very simple, just stretch it, Just stretch it, hold it a few seconds. Unidirectional is sufficient, and it works very well. And then you can just reform the pupil with viscoelastic. So in this case, it's definitely a narrow pupil. It's not an A-1st case. This is post-glaucoma surgery with posterior synechiae. I prefer synechial lysis using viscoelastic because it's less traumatic for the pupil. And then, very simple, very cheap solution, and you obtain a stable 5 millimeter pupil with and round with viscoelastic, as you see, viscohydrisis. Most of you use iris hooks. I have used them in the past. Just the one thing not everybody really uses is that the position and the angle are quite crucial, meaning that you need them to create the incisions really peripheral so that you have a flat angle of attack where you get an easier engagement of the iris. And even more important, that you should put one iris hook close to the incision to get away the iris from the phaco tip when entering. And when you put them here and here, so there is iris which is very easily damaged by the phaco tip. I do not have videos of iris hooks. It's very straightforward. I don't like it because I find personally that the pupil don't look as nice as with the following device, which is the Malugin ring, which has a very short learning curve, just a few tips and tricks which you have to master. But once in place, this is at present, in my opinion, the best solution for narrow pupil surgery. So here I have an extreme case of hypermature intumescent cataract, where actually there is posterior synechiae throughout the entire posterior surface of the iris. It took me 5 minutes just to break synechiae to some extent. Pretty horrible case to deal with. It's intumescent as well. But once you get the Malugin ring in, which is doable in all cases, really not very difficult. You just simply go to YouTube or iTube, even better, and look at some videos and be a little bit careful. That's all. Engage the lateral edges with the two loops. You can get some help with a second instrument if you want. Dislodge the proximal one, and I like the bimanual engagement of the superior loop because it's less traumatic. But once you have that ring in place, surgery is really just smooth and simple. Again, bimanual dislodging. This is the one trick you should know. I did this on purpose. Very often, one of the loops doesn't get into the injector. So, very easily solved. Just push it a little bit down and take it out. I think that this is really my personal favorite. Until present, I do recommend it for those who have not tried it to try it. There are many other rings actually on the market with which I do not have personal experience, There's a novel one which will come to the market in due time, been developed by an Indian ophthalmologist, Dr. Bhattacharjee, who has presented it last year in several congresses. And I have a brief experience with it. The one difference is it's a single thread, so with no loops, ring. And this is actually my first case. And so I had no experience whatsoever with this ring. So probably you can do it a little bit faster and easier, but I haven't figured it out yet. So this is a single thread with, where it undulates, and engaging the iris is not very difficult. Quite straightforward. And like the Malugin ring, once it's in place, the whole surgery is a no-brainer. Watch now here, in this area. So there was, one of the loops was there, but now it has gone underneath the iris. So next time, I think I will make sure that this kind of area will be under the incision. So now I cannot grasp the ring very easily. I have to dislodge it first. Otherwise, I could have taken it at the superior side. But once you get hold of it, that is the big difference with the Malugin ring. Taking it out is, it's the simplest thing you can imagine. It's extremely simple. So I foresee a bright future, actually, for this device. Thank you.
Thank you, Dr. Tjia. We'll have the voting again and see if Dr. Tjia convinced you to alter your way of surgery. And if anybody has a question, he can use his iPad, his pad, just to ask it.
Just do me a favor and
so
vote for the Malugin ring.
Can we put on the question again, the narrow pupil management? Is it sphincterotomy, iris hooks?
You can still change.
Rings?
Yes. Thank you very much.
Okay. So, very good. Wait, it's not final.
The audience is just kind.
Okay, we change some of
That's the trick, just ask kindly.
We changed some of the audience mind. Okay, thank you very much, Dr. Any next question? Oh, wow, good. Okay, stop it now. Thank you very much, thanks a lot. Now, for the next question, managing presbyopia. What would you do? Monovision, bifocal, trifocal, or accommodating IOL? So this question for the audience to vote. We'll give you 10 seconds. Okay, so it looks like monovision wins just for now. Trifocal comes next, bifocal, and accommodating IOL. Okay, so we'll ask Dr. Bilbao just to give him experience on the subject, and then we'll vote again and see if we have changed your mind again or not.
Thank you very much, Dr. Hesham. Thank you very much, Allah, for your very kind invitation to this wonderful Congress. And thank you very much, especially for inviting me to this cataract session with such a wonderful and worldwide recognized surgeon. For me, it's like being invited to play a football game with Cristiano Ronaldo and messy. It's really wonderful, so thank you. What we're going to discuss in a few minutes is the treatment of presbyopia after cataract or lens surgery. In only a few minutes, I will be only able to give you very general ideas, which would be maybe obvious for the most experienced surgeon, but hopefully can be helpful for the a bit less experienced surgeons. Let me just make a short introduction about my practice. I did most of my ophthalmic career after I became an ophthalmologist in Clínica Baviera, which is a clinic founded by Dr. Julio Baviera in the mid-90s in Valencia. It's a city in the east of Spain. That started growing, and now the group has now over 70 ophthalmic clinics in Spain, Austria, Germany, and Italy. We are more now than 150 ophthalmologists, and we have performed a great amount of cataract and refractive procedures during the last years. We have computerized clinical files that we can share among all of us, and the strong points we have to have grown so well, it's the scientific analysis of our results and the friendship and the sharing of our knowledges between the college. We have a live intranet communication among all of us that is continuously working. Also the efficiency in the management of our cases. Let's center in the presbyopia correction after lens surgery. This can be performed with three types of, or with three type of focus, with accommodative lenses, with monovision, or with multifocal IONs. Regarding the accommodative lenses, these produce or these restore near vision when the patient tries to focus on the near by a change in the lens optic. Different types of accommodative lens has been developed with different type of optics, single optics, double optics, or changing flexible optics. Possibly in the world, crystallines and the synchrony models have been the most used worldwide. Nowadays, however, these type of lenses are very infrequently used. They provide good vision, but poor results in the long term have been published. And besides, the lens design could produce a further anatomic and visual disturbances related to the capsule and lens back fibrotic changes. However, we don't know what's going to be the future, and this deserves further investigation with this type of lenses. Regarding pseudophokic accommodation, with which I have a very large experience, let me explain you first what is monovision. It's a situation in which an eye focus for near distance is what we call the reading eye. Oh, sorry. The other eye focus for the distance, that's what we call the dominant eye. And the suppression of the blurred image can produce a useful vision for near, intermediate, and distance vision. The goal of monovision is to provide a useful vision for distance, intermediate, and near in order to minimize the spectacle dependence. Why do we still perform pseudophakic monovision? Because this has been a technique used for a long time, and it has demonstrated a quite high success with contact lens use and with LASIK, with laser refractive correction. And it can provide, it was demonstrated, a good intermediate vision, acceptable near vision, and a moderate distance vision. When and how do we perform monovision? I can extend and explain you all the detailed examination of a patient, but let me tell you that monovision is based in the physiological capacity of intraocular blood suppression. We need to have patients with an absent or moderate anisometropia. We need to have patients with absence of low amblyopia. They cannot have more than 3 lines of difference between both eyes. They need to have good previous stereoacuity. They need to have a lack of exo or endophoric shifts, and they need to be motivated with this type of vision. Most of the patients, you must know it, adapt well to this kind of vision if they don't have any stereopsis or binocularity problem. Women do better than men. Smaller pupils, patients do better than larger pupils because of they have more depth of focus. We do perform, if they don't have a dense cataract, a frame trial, but we usually don't do a trial with the contact lenses. We can discuss later if you want to. And regarding the ocular dominance, the trick of this type of vision is to have an absence of a strong dominance, because we need that a suppression exists with a blurred vision eye. Many studies have been performed regarding the cross monovision to see which is the dominant eye, and if it's better to leave the distance the dominant eye or the dominant eye for reading. And several studies have demonstrated that there is no clinical differences. What amount of monovision do we leave? Between 125 and 1.5 in the dominant eye. If we leave more than 1.5 diopters, patient will have more spectacle independence, but they will be more uncomfortable, and there will be a greater decrease in stereoacuity and contrast sensitivity. It is very, very important that an accurate postoperative distance correction for the dominant eye can be get. And the patient must be motivated for this type of vision, because they have to adapt to it, and they have to be aware that they will use, or they may use, thin spectacles for activities with precision, both for near and sometimes for distance. What problems can we find with monovision? As I told you, there's a technique in which there's a decrease in contrast sensitivity, a decrease in stereopsis, a slight decrease in distance visual acuity. Sometimes it might be difficult to understand for the patients, especially if they heard about the multifocal lenses. They need glasses to help, for example, for prolonged reading and night driving. We need a very accurate emmetropia in the distance focus eye, and it's a time-consuming, especially before the operation, until the patient understands it. But what are the advantages? In my experience, they get a good percentage of glasses independence and a relative good quality of vision. They have less positive dysphotopsias than multifocal lenses. It's technically partially reversible, and vision can be easily improved with temporary thin glasses. It's a highly accessible alternative due to a lower lens cost, and this may be an important issue in some settings. Regarding the multifocal lenses, what are the preoperative counseling and the patient selection we must have? During the last year, this type of lens has increased in their use worldwide. And nowadays, it's a more performed refractive surgery technique to treat presbyopia. These lenses can lead to a reduction in contrast sensitivity. They also can produce worse quality vision in low or dim illumination conditions. They produce dysphotoptic phenomena, and they can transform a technically perfect procedure into a failure with an unsatisfied patient and a worried surgeon. What are the keys to success with multifocal lenses? We must perform a technically perfect procedure. We must know the technical characteristic and the previous clinical results of our lens implanted. We must consider the clinical characteristic of our patient. We must consider the lifestyle and personality of our patients before deciding what lens. And we must manage the patient adequately in the clinic. Regarding the surgical procedure, no big details, just think of a very, very thorough preoperative examination, including binocular function. We must do an accurate biometry, and we must have thorough knowledge on lenses calculation formulas. We must aim for a very closed emmetropia. We need to do a perfect surgical technique. We need to clean completely the posterior capsule. We need to have experience in treating intraoperatively astigmatism, and we must have experience and the possibility to do a later corneal enhancement in this patient. Regarding the clinical considerations of the patient, this would be too long, and it make my talk too long and too boring. Let me just refer you to this wonderful review that was published at Journal of Cataract Refractive Surgery last year. It's very, very useful. Just a few tricks. Considering the ocular comorbidity of this patient or of the patient, for me, multifocal lenses are contraindicated in monocular patients, in patients with maculopathies or retinal progressive dystrophies, in patients with central or dense corneal scars, in patients with severe dry eye despite a previous appropriate treatment, in patients with pupil abnormalities, in advanced glaucomatous or optic nerve disease, or in patients with progressive and severe zonular weakness. What are the personal considerations we must do with this patient? That's very important. Information is basic for expectations, and patient expectations are, for me, the clue between the success or the failure in this type of surgeries. Regarding the expectation of the patient, we must ask the patient about his or her expectation. We must ask him about the personal references from other previous patients to explain the possible differences between his case and the case of his or her friend or relative who sent us to it, okay? Discuss about the patient needs in far, near, and intermediate vision. Ask about night driving frequency, and anticipate postoperative situations for the patient and explain their solution. If he reads a lot, think about telling him before the operation you will need some light in your reading area, or things like that, okay? Regarding the information we provide to the patient, we must teach the patient about the use of these multifocal lenses, explain them about the 2 or 3 focus instead of an infinite focal points, insist them on the impact of proper illumination, explain there will be dysphotopsias, glare, halos that will be permanent, more intense at the beginning but permanent. Explain neuroadaptation. Insist on changes compared to current preoperative situation. If they're hyperop and they're using glasses with magnification, their distance vision will be less accurate after the operation. If they're myope of low refraction, their near vision will be worse than his previous before the operation. All this must be explained and stressed. Insist and disabuse visually demanding patients. What are the keys of success regarding the patient? Patients with good profile are patients with a firm wish of a spectacle independence. Patients with positive personality, and patients able to accept limitations about the perfect size. Bad patients are those who doesn't mind wearing glasses, who have a type A personality or perfectionist, patient in which the goal is a perfect sight rather than a good quality of life, and patient with a heavy dependence of night vision for specific job requirements. With a proper preoperative examination and a detailed and honest discussion, some patients will self-discard these lenses, but we will ensure many, many good results. After the surgery, we must assume a positive role in the outpatient consultation. We have to spend time with the patients when it's needed, and we have to insist on the earn of quality of life before and after the operation. But what multifocal lens should I implant? Many models have been described in the last years, and every 1 or 2 years we have slight improvements, technical improvements that make that the multifocal lenses are slightly better than the previous ones. Oh, sorry. In Clínica Baviera, since for the last 10 years, we've been using multifocal lenses, and we've up to now implanted nearly 50,000 lenses. And we've been implanting many different types or models. I'm not going to enter into the discussion of each of them. My colleague, Dr. Mesa, yesterday did a wonderful presentation about the specific characteristic and clinical performance of all of them. But just tell you that we have a large experience in bifocal rotational asymmetry lenses, the M+. But we also have a large experience in bifocal diffractive lenses, especially with the Restor and the Acrylisa. But how are we performing multifocality now? With trifocal lenses, with both the Zeiss trifocal lens, and especially in the setting where I'm working in Madrid, with a trifocal Physiol fine vision lens. It's a lens, I was a bit worried about the design and the hydrophilic material when we started using it, but has a very good surgical centration and easy and nice intraoperative behavior, with good stability in the back after 1 or 2 years we've been using it. provides a good, far, near, and intermediate vision. It performs slightly better with residual ametropia than the diffractive bifocal lenses. And we have a slightly better satisfaction rate. They are an excellent option for every multifocal lens candidate. I don't have to choose what lens to implant in my multifocal candidate patients. I think they're suitable for all of them. That's our experience. And nearly all of them got 100% glasses independence, but still they'll have loss in contrast sensitivity. They'll have positive, and a few of them also negative dysphotopsia. The cost of these lenses is higher than the previous one, and we still have some concern about the long-term anatomic behavior in the capsular bag of these lenses. And also, in the case you're going to start using them, look at this. This is a patient on the right side, which was just, if you revise your patients after the surgery, on the left part of the screen, this patient suffered from a no pacification that is fortunately transient, and that is due to the change in the temperature from being the lens outside in a cold storage room to enter into the eye. It is due to changes in the polymerization of the hydrophilic polymer of the lens. Fortunately, as I told you, it is transient and it goes in 1 or 2 hours. Don't be afraid if you see, or don't be frightening if you see it, or if you revise your patient when going out from theater. So finally, multifocality, monovision, what is the best option? If we revise what the literature has said about this, and we compare, and we revise the studies published comparing both types of lenses, we have 2 studies recently published in Journal of Cataract of Refractive Surgery and 1 in ophthalmology. And although the multifocal lenses are all models, regarding the spectacle independence, multifocal lenses are the winners regarding spectacle independence. In conclusion, pseudophakic monovision and multifocal lenses have been proven to be effective in the correction of presbyopia. They provide a good range of vision and good range of spectacle independence, a high satisfaction rate, and a clear improvement in the quality of life of our patients. However, none of them is a perfect solution for presbyopia. For distance vision, both have proven similar good results. For intermediate, monovision used to be better, but now, with the trifocal lenses, they seem to be very similar. For near, multifocal lenses have a better vision. Multifocal lenses provide more spectacle independence, as I mentioned before, but also significantly more dysphotopsia, more enhancement corneal procedures, and more lens exchange rate. I would like to thank you, my colleagues, Dr. Javaloy, Dr. Gonzalez, and Dr. Jovet, because they helped me really very much in the preparation of this presentation. And honestly, I would like to thank you for your kind patience and attention during this presentation. Thank you very much.
Thank you very much, Dr. Bilbao. Now we'll have the vote again. If you change your mind, we'll see the can we repeat the vote again now about the multifocal IOL? And there's a question for you that there is no, one is mentioned that there is no single answer of the presbyopia treatment. It differs with each patient. Do you agree about this?
Beg your pardon?
That there is no perfect answer for the presbyopia correction. Would you agree? There's no perfect lens. Do you agree about this?
Yeah. Well, I couldn't understand very well your question.
The question is, there is no single answer for the presbyopia treatment. It differs with each patient. Do you agree about this?
Absolutely. I have, in a very personal relation, I have my father and my mother. They're both of them about the same age. They were both of them hyperopes around 3 diopters. I did a multifocal lens procedure on my mother. I will do this year a monovision on my father. I really love them, both of them, with the same amount.
Sure. Okay, so it looks like the monovision is getting the more popularity here. So we didn't convince them about the trifocal. Thank you very much. Thanks a lot. And this will adjourn our session. Thank you very much for coming, and hope to see you soon in the next.